much of what my presentation will be linking back to are those key system strategies to help as we propel forward with a population health mindset as we continue the journey towards defining and realizing what is value-based care. All right, so at that, just to ground us, I'm going to start with just a baseline definition of what is population health. There are more definitions for population health than you can probably shake a stick at. And across industries, you might get very different mindsets and opinions of what is population health. And so we're going to be taking a look at a definition that I really like from the American Journal of Public Health. I believe it spans nicely across industries and can bring both from that macro level perspective down to that very molecular micro level. Population health, distribution of health outcomes of a group of individuals, the patterns of health determinants within that group, and then probably the most challenging is the policies and interventions that link those two concepts together. Defining and grounding in what is population health is probably the easy part, right? So where the challenge comes is more from going from conceptually what is it to tactically how are you going to achieve that? How are you going to operationalize that? How are you going to achieve your actual objectives? And so what I'm going to be spending the majority of this presentation this morning on is looking at 4 core competencies that really bring the foundation to help us to realize this somewhat nebulous concept of value-aligned care. The 4 components are value-based contracting, clinical care model, clinical quality, and last but not least, the foundation that drives this bus, data and analytics. So we are going to now break those down. All right, value-based contracting. It is the shift from fee-for-service to value-aligned contracting. As much as there are opportunities for improvement, it has been the primary mechanism for funding healthcare from a very transactional business model. And as we move into the value-aligned reality of contracting, some of the structures in place as of now are shared savings arrangements, pay for performance, payments specifically tailored around quality incentivized payments, gain share, contracts with both upside and downside shared risk, and the system strategies for Fairview specifically are around Medicare Advantage and medium and large group employers within that commercial space. These growth markets that have been identified are actually subsets of larger population segments, those being your Medicare population set, Medicaid population, commercial payers, and then somewhat newer entry into the market that we're continuing to still wrap our arms around fully understanding is the individual market, the market exchange, which brought quite a bit of disruption with it. And so within the Medicare population, the Medicare Advantage contracts certainly bring with them a more favorable outlook from a care organization's perspective of how to have work truly toward that triple aim, and lesser so with the traditional fee-for-service Medicare shared savings programs that have been in existence. And then within the commercial space, growing our relationships with the mid to large group employers. That market is quite favorable, and one of the, from the perspective of operationally going out and working with these medium to large group employers, is where can we work together? So we're going to spend a lot of focus, and I know James and Eric have as well, around crossing industry boundaries. And knowing now, I think it's been well established today that we, from healthcare organization, have about, at best, I would say 20% influence into this. And so how can we work with those employer groups and help of what are they doing with their employee occupational health, how are they working with what are our patients and the members that we can surround and to move those patients forward. Value-based contracting, the second arm is the network. And so heard both James and Eric speak to the concept of a narrow network, somewhat of a play on words, but looking at that more of a distinctive network. And so what's the difference between a narrow network and a distinctive network? Narrow network is just as James portrayed, sort of that gatekeeper mentality, where a distinctive network is more conceptually of the clinically integrated network of care providers that are coming together both around clinical quality, total cost of care, and really integrating together to bring impactful changes. At Fairview Health Network is comprised of Legacy Fairview Medical Group, Legacy Healthiest Medical Group, and then certainly our Fairview Physician Associate Aligned Independent Practices. A specific area of focus within that network and contracting space is really how do we look at and start to move forward with bi-directional terms of participation. What might that look like? How can we bring that to the next level from the network relationships that we've had historically? Eric did such a fantastic job speaking to the clinical care model and really that being the core of what we do. It can be easy to, within population health, to really focus on the business aspect of population health management. But truly at the center of that is our patient, right? And as James stated, that is our laser focus, and in high quality clinical care is essential to what we do. The additional focus into primary care and that continuum care, as well as the service line model to follow that patient journey longitudinally, facilitated transitions management, all of these with the intention of reducing unnecessary waste and bringing a higher value. In the care management space, how might we really move this to a new paradigm in care management, shifting from very transactional and fragmented care management structures. So really the predicament that we find ourselves now is that in efforts to better reduce total cost of care and improve clinical quality across industries have emerged multiple different efforts towards care management. We just need to manage the care better, bring in disease management, care management, and that will reduce this waste. The end result is where we find ourselves today, which is very siloed care management, and the patient in the center of that being care managed by the payer and the community partner and the care system. And then within the care system, care management from post-acute, from primary care, population health. There's more care management than you can even wrap your arms around. And so as an organization, bringing that together and reducing the care management waste that currently exists so that we can push that forward in a well-coordinated manner. And so as an organization, we are bringing together all of those siloed care managements within the organization. And as we're going to get to as we move further into this is how can we work with other industry leaders that we can coordinate across even outside of the system. Clinical quality. So dynamics in clinical quality management. In this, to link quality back to contracts, nearly every, I wouldn't say nearly, okay, every accountable value-aligned contract that you would always have a quality component, maintaining that high clinical quality. And so anything from hard quality dollars to quality scores used as a multiplier toward the financial metrics, but that financial contractual piece is recognized in these agreements. As we continue to grow our competencies in the Medicare Advantage space, STARS measurement is key to that. They're historically, as a care system, have been very focused on the publicly reported quality metrics. So Minnesota Community Measurement, our ACO measurements for our Medicare population. And moving down that pathway into the Medicare Advantage is really stretching us to partner even more closely with our payer partners around these what have historically been HEDIS measures that the payers have been very focused on, and how do we come together with our payer partners on clinical quality. And then last but not least, core competency around data and analytics. Data is essentially, it is the foundation of what drives the identification of key opportunities. And I refer to this as a shifting foundation. Essentially, that is where we now find ourselves. Historically, data has been very disparate. Comes from, it's very payer-driven. Care systems receive data from all payers in multiple different formats, multiple different components. High variability, not just in the data that's received, but the methodologies that are used from individual payers to really target down from that payer-driven perspective what they might want to be driving forward as the key focus areas. It's very reactive. I know James spoke quite a bit to that. This historic approach, particularly from the payers, can have anywhere from 3 to 6 month lag before we're actually reviewing and then reacting to that data. Moving forward into a future state of a business-driven model from the care system with a very intentional receipt of data points from our key partners, a consistent and efficient approach into how we absorb that data, how we analyze the data, and then how we identify the key strategies to then take action. James has departed, but as a mathematician, he would recognize that this is not going to be a mathematical equation you would find in a textbook. The key message to drive home here is that we have more data than we've ever had before, exponentially. The analytics, the methodologies, the models to analyze that data is coming at a rate that that wouldn't even been imaginable 5 or 10 years ago. And then taking those two into account, the conclusions that can be drawn, and how do you focus out really where do you want to, as an organization, target your interventions within a population. And so I am going to spend just a few moments just to speak to one of the key tools that we've implemented embedded within our EHR, Healthy Planet. A lot of confusion around Healthy Planet. It is not a specific software product. What it is taking are multiple functions that exist and some that are new within that EHR, bringing them together in a manner that can absorb multiple datas and to help to integrate both that claims perspective, which can bring part of the patient portrait that we don't always have fully available within the EHR, some of that being pharmaceutical insights as well as care that is received, much of it specialty care and unplanned care from outside of our system, and integrate that in with the rich clinical data that we have for patients that have identified Healthy's Fairview as their first choice to receive care. And as we look at this, to look at rather than the dart shooting of individual payers bringing multiple different predictive risk models and reactive risk recommendations, that as a system, how do we bring that all together to risk stratify our population in such a manner that we can predict the care needs within segments of population to bring sustainable improvement within those areas. And I'm going to leave this presentation with a visionary, I would refer to this as a visionary thought process, just to kind of challenge us and to stretch us into the future. So to imagine a paradigm shift, care systems, we can no longer operate without fully integrated partnerships. What if leaders across industries, cross boundaries, form partnerships that otherwise historically have not been formed to integrate differently in ways that we have not previously to achieve a common goal? And if that common goal had shared, evenly distributed risk, gain share, would that redefine how care is delivered and paid for as we move into the future? The one question I actually received from a couple of colleagues was, Jess, how do you identify what key diagnoses or what key conditions most to bring initiatives to bring change? And my response to that is I'd like to challenge us to move from that traditional mindset of identifying one specific disease state, which does not bring the lasting, sustainable change to impact the triple aim around populations, and to move more towards alignment in which we, as a care system and industry partners, can collectively, across the care continuum, bring lasting change to those populations. And that is one thing that I'm extremely excited for as Fairview is moving into the service line model, is that we can start to think about populations with those care needs in mind. So the question was, have we yet taken and integrated data from Legacy Health East, Legacy Fairview, collated those to have any meaningful findings with a specific focus on disease state? And my answer to that is yes, we have. And ironically, just as soon as you collate the data together, then my natural next response is, what does that data look like separately? And I think that in time, we'll get away from that. But really looking for, there are, in Legacy Health East, areas where there has just been accelerated clinical and financial outcomes and opportunities. And with Health East, some of those are similar and some of them are quite different. And so there still is great value in looking at that data both separately and collectively, knowing that the solution set will be across the organization. And with that, the second half of the question was specifically towards identifying top 5 disease state is what I had heard. And my response to that is a yes and, right? So yes, there are kind of your top culprits that always come to mind, CHF and your COPD, especially around your inpatient costs, pharmacy costs, and really to get back to looking at that from a payer-driven patient population segmentation, the answer to that is very different and very specific within those. So my response to that for a Medicare population, both fee-for-service and Medicare Advantage, is going to look very different than a Medicaid population. And those areas of focus are going to be quite different.